2026 from 11:30 a.m. Indian Standard Time and 10 p.m. Pacific Time. We have Dr. Rahul Banerjee from Seattle, Washington, speaking to us on bispecific antibodies in multiple myeloma, what's new and what's coming. Let me introduce our discussions for the day, and they are well displayed here in alphabetical order. I will pause for a while for you to look at all our discussions for the day for very eminent hematologists, hemato-oncologists, as well as medical oncologists all across the country. So these are our discussions for the day. And now it's time to introduce our guest speaker for the day. We have with us Professor Dr. Gerald Redditch from Seattle, Washington, USA. Let me introduce Dr. Gerald to all of you. Professor Dr. Gerald is Professor, Clinical Research Division at Fred Hutchinson Cancer Research Center, Seattle, Washington, USA. He is a member of the Clinical Research Division, the Director of the Molecular Oncology Lab, and the Kut and Sling Adult Chair at the Fred Hutchinson Cancer Research Center, as well as Professor of Medicine at the University of Washington School of Medicine. He is also the Chair of the Leukemia Translational Medicine Committee of the Southwest Oncology Group. He was the inaugural Chair of the National Cancer Institute and National Institute of Health Leukemia Steering Committee and a past member of the Board of Scientific Counselors of the NIH Genome Research Institute. He is a past chair of the CML Committee of the National Comprehensive Cancer Network, a member of the European Leukemia Network, CML committees, and is on the scientific board of the International CML Foundation and the Max Foundation. He currently leads the laboratory committee of the NCI AML Precision Medicine Initiative and leads the foundation of the NIH's program in measurable residual disease MRD in acute myeloid leukemia. His laboratory research centers on the molecular biology of response, resistance, and progression in adult as well as chronic leukemia. In addition, the CLIA Molecular Oncology Lab provides a molecular diagnostic support for many institutional, US intergroup, international, and pharmaceutical trials. He was awarded the International CML Foundation Award in 2017 and the Washington Global Health Alliance Partnership Award in 2019 for his lab's work on diagnosing CML in the developing world. Today, he is going to lecture us on further updates on chronic myeloid leukemia in 2026. Well, thank you so much. I stop over here. Over to you, sir.
Great. Good morning, everyone. Let me try to share my screen here. This has worked in the past, so I'm cautiously optimistic. There, can everyone see that?
Perfect, sir. Please go ahead.
Great. So thanks for the invitation, everyone. Good morning. It's 5:30 a.m. here in Seattle. I'm usually an early riser, but I usually don't have to say anything for about an hour and a half or 2 hours. So this will be new for me. So my apologies if it sometimes my tongue trips or I have to drink a fair amount of coffee. So let's just plunge into it. Let's talk about what's going on in CML. It's still a very interesting and active disease. This is sort of a timeline of all that's gone through and how fast we've been moving. Right. So in the 85s, the lab pretty out of UCLA discovered the BCR-ABL rearrangement. The Philadelphia chromosome was discovered south of this about 1960 by Peter Knoll. But the molecular lesion was found in 85, and then really things have been changed in a rather breathtaking fashion. When I started doing taking care of CML patients and the like, it's about in this region here, where we just had hydroxyurea, interferon, which only a few people responded to, and that was really the advent of transplantation. But then once we hit about 2000, we've had an amazing proliferation of drugs that are shockingly effective. Imatinib, then dasatinib, nilotinib. Oops, sorry, what happened there? Bosutinib, and then now the new drug, asciminib. Let me get rid of this because you want to see this. So a lot of what we're talking about here is some of the new uses of asciminib. So this is sort of a courtesy. This is a slides courtesy of my friend Jorge Cortez. This is kind of looks at the evolution of CML therapy from the treatment from the hydroxyurea to the tyrosine kinases to monitoring, where originally, when I started doing this, we went cytogenetics and then fish, and then PCR kind of changed the whole landscape of how we could do monitoring. Endpoints where we went from in the old days, if we got a complete hematological response, that was fantastic. Um, Complete cytogenetic response when we first started doing the iris trials and the like, but now we've moved both in trial design and in drug development to the markers of molecular response by MMR and MR 4.5, which is important in discontinuation work. The goals, we've gone from just symptom management to and perhaps increasing survival to really talking about now event-free survivals and TFR. And then the patient goals, originally it was just survival if we could do anything to the disease at all. But now we really are talking about quality of life and cure. So a huge rearrangement of our goals, and we're really kind of the poster child for what precision medicine is all about. Now, this is the impact of tyrosine kinases in 4 graphs. Keeps wanting to do that. So this is old data looking at patients and the usual transformation of disease that occurred before we had tyrosine kinases. Most patients were diagnosed with chronic phase, which had a average lifespan of roughly 6 months. I'm sorry if it's just occasionally doing this. People who would eventually go on without curative therapy with transplantation to accelerated phase and then to blast crisis, which was inevitably fatal. And for people who couldn't get a transplant in the pre-TKI days, this is sort of the biological clock that went on in everyone. And when I first started doing cancer stuff, that was my research goal, was to understand this biological clock, which we still don't understand very well today. The top right corner shows really the impact of tyrosine kinases. This is looking at patients with chronic phase disease by decades. So you can see down here with the busulfan, your 6 to 7 year survival. You marched up, here's the age of interferon, and then here we go with interferon transplant and now imatinib. So a huge swing in survival just with the introduction of tyrosine kinases. Because of this now, this is looking at life expectancy from years of diagnosis from the 70s to the 2010s. That's going to drive me nuts. The normal life expectancy, and this is now life expectancy with patients with CML. So in most patients, now at least in the European and America's kind of the wealthier countries, can get normal life expectancy with CML. And then lastly, which we'll talk about, discontinuation. When we first started treating people with tyrosine kinases, we figured they'd used to have to be on drug for the rest of their life. In fact, people who have had deep molecular responses for a number of years can get off therapy, and about roughly half of them will stay off therapy. So again, this is kind of with the status and remarks the unbelievable transformation we've had in this disease in just 20 years. So there's now 3 big questions in CML, and here is conceptually the first one is who responds to therapy, which patients do that versus the patients who do that. And this is BCR-ABL level, so this is the patients that you want, the response you want to see with the BCR-ABL declining over time. And I've made the proportion, the dimensions of the line with how often this happens, so most people in the chronic phase respond. Who relapses on therapy? Most people do well, but there's a proportion of patients, roughly about 20%, whose disease will come back. And then who can discontinue therapy? Whose disease can go low enough that you can stop therapy and they will remain low versus those who then will come up and relapse and have to go back on therapy. So, so usually I don't make transitions this obvious, but I figured I'd be sleepy, so I got to remind myself of when I'm transitioning. So as you can see, here's what we're going to do here. We're going to talk about picking our initial TKI and predicting response. So this is, again, who responds to therapy. And this is work that we did. This was our first whack at looking at molecular response to therapy in the IRIS trial. And we found out that if you looked at the 12-month value and looked at BCR-ABL decline, a 3-log decline in BCR-ABL made a difference between these 2 curves and these curves. And in here, roughly the 1% BCR-ABL by international scale, that's roughly what complete cytogenetic remission is. and 0.1% is MMR and the like. So really the major benefit you get out of the survival difference in tyrosine kinases is at the CCYR phase. And if you're that or better, you do fantastic. And if you don't do that by 12 months, then you've got to think about some alternatives. And then I have a few slides here just to kind of show the comparisons of the large randomized trials. We have that kind of under our feet. This is from the IRIS trial, which was the largest phase 3 trial in leukemias ever conducted, accumulated about over 1,000 patients in just 12 months. And this trial was concluded early because we powered the study for a complete cytogenetic response of interferon to be roughly about 25%. In fact, in the trial, only 7% of people got complete cytogenetic response. And so the trial was stopped early. These are the results of looking at the imatinib and interferon arm. And these arms are so close because almost everyone crossed over from interferon to imatinib within the first year. So that's when once you crossed over, that survival advantage persisted. So these are what the drugs we have approved in the US, and they vary by country, but in the US for first line therapy, we have imatinib, dasatinib, nilotinib, bosutinib, and asciminib. Ponatinib has not been approved for first line therapy, mostly because of the cardiovascular toxicity. And then in accelerated phase, all of them except asciminib because they haven't really been studied there. And in blast phase, all except asciminib and nilotinib because there hasn't been a study of blast crisis in nilotinib for some reason. So we have kind of an embarrassment of riches of possible tyrosine kinases to use. And we and others have drawn these maps about responses, about when you kind of on a traffic light, when things are good and when things are bad based on what the BCR-ABL level is. And these are the points that we want to make is um, for the level of response kind of correlates with what outcome you're looking at. So early molecular response is usually defined at a 3 or 6 month BCR-ABL level of less than 10%. Most people, when they're diagnosed, have a BCR-ABL level of 50% to 100%. So that's roughly about a log decrease. It's associated with improved survival, progression-free survival on first-line TKIs. So if you're below 10%, that's what you want to get by 3 to 6 months. 1%, which is roughly the CCYR, is really where the first step that you get superior survival. So that's your first kind of road, fork in the road. MMR, which it's a long story I can tell later. We kind of made this term up. We never really expected it to stick, but it turned out that it was, for whatever reason, biologically significant. That's a BCR-ABL level of 0.1% or low. It's a 3-log reduction from the starting point. And this increases your chance of achieving deep molecular response and is associated with improved progression-free survival. And DMR, deep molecular response, is anywhere from 4 logs and lower, and that's what you really need to get discontinuation therapy and remain in TFR. So this is kind of a comparison of randomized studies that are pharmaceutically driven. I will say that we performed a study at SWOG looking at this comparison, which was a non-pharmacological study and showed exactly the same thing. So these studies I think are all pretty legit. And the remarkable thing about them is if you look at response rates is the results of all the randomized trials are remarkably similar in that you see a better rate of early responses, like MMR and MMR 12 months, deep molecular response. You see a benefit of the second generation TKIs over imatinib in all these studies, and the magnitude of those differences are almost identical, which is really quite astonishing. Oops, I don't know what to do there. Less progression with the second line agents. So in all these values, you'll get dasatinib versus imatinib or nilotinib, bosutinib, asciminib, same difference. The main difference, the interesting thing though, is that when you look at overall progression-free survival, they're all the same. So for some reason, early response change with molecular response and the decreased reduction of the blast crisis have not been of a magnitude to really make an effect in overall survival. And I don't know if that's because there really isn't any effect or if because the survival is so amazingly good that you'd have to have the world's largest trial to even get close to the power you would need to discern a difference. So I think for the bottom line thing to remember is that you're going to get a faster response and probably, at least in the short term, a deeper response with the second generations and beyond with asciminib. But you're probably not going to affect survival much. These are just going to be a couple of slides showing this effect. These are from the Decision trial, the dasatinib versus imatinib. So if you look at MMR, that's dasatinib, that's imatinib. They stay apart, they never quite catch up. Cumulative response to 4.5 log reduction, same, it's going to be a little bit better than dasatinib. They all kind of improve with time, but you really never cross over with imatinib getting up to the dasatinib levels. This is from the ESC&D trial, which was imatinib versus two different doses of nilotinib. Again, there's the gap, imatinib and the two different doses of nilotinib. There's no difference really in the two doses of nilotinib, which is kind of interesting. So most people go with the lower dose because that's less toxic. But again, same theme that you had with dasatinib. Bosutinib, same exact theme. They're going to be different, imatinib in the second generation, and they're by about the same margin as the other trials. And again, they all march up and get better with time as you stay on drug, but you never really close the gap. Now, the new game in town are these so-called myristoyl pocket inhibitors or allosteric inhibitors. And what that amounts to is that how most TKIs work is by blocking this ATP binding site. And so when you block that, the tyrosine kinase can't pass phosphates onto its recipient proteins in the chain of command of signaling transformation. And the tyrosine kinases basically block that. And when mutations happen in the tyrosine kinase domain region, they basically prevent the tyrosine kinase from binding in here, and that's how you get complete activation. So asciminib works in a different mechanism. It turns out that in the folding of this molecule, you have to have this pocket open, sorry, so that the molecule can fold over and get into activation state. And this asciminib basically blocks that, and so the three-dimensional conformational changes can't happen in the protein, so you can't get any activation. And it was first invented to be in the context of patients with tyrosine kinase domain mutations because you can block then the BCR-ABL activity by inhibiting a different site apart from the ATP pocket. But turns out that it works very good in the upfront setting. This has been kind of a marketer's dream because they can have these things ask. So this is the ask for first. So this is this is a drug. This is a trial where you basically compare asciminib frontline chronic phase patients to any other TKI that the investigators want to use if they're randomized to that arm. And again, here you see asciminib, all the other tyrosine kinases. And then this is the imatinib stratum, where this is asciminib versus imatinib. So you see a pretty big gap. And this is asciminib versus other second generation, where you see maybe a small gap, but I don't want to make much claim there. So you can say that at least if you look here at MMR4 and MMR5 at different out points, asciminib is going to be a little bit better than all the TKIs or the imatinib one, and marginally better as well here. But I think most people in the claims will say that we clearly see a better drug of response to asciminib versus TKIs. Asciminib versus the second generation drugs probably better, but they really haven't been powered to look at that. And I think the benefit is going to be a little bit different. The benefit with the asciminib compared to the other TKIs is that it really seems to be less toxic. So you get the same efficacy with less toxicity. So this was in the Ask for First trial. They looked at time to discontinuation due to AEs. And if you look at the odds ratio, it's about 4/6, so about half as many patients have to go on and change. And if you look at the things we worry about the most with arterial occlusion events, all patients who had asciminib have about 2%, other TKIs about 2.9%. Imatinib is the safest, none. So that's if you really have a vascular patient, asciminib is by far or imatinib is your best drug. Here are again the deeper responses that I mentioned. This is the CCYR rate versus imatinib for all of these drugs in this trial. So remarkably similar. MMR, again, remarkably similar imatinib versus these second generation drugs. plastic inflammation less. Um, so again, probably as good as the second generation drugs. This is ask for START, which was just simply asciminib versus nilotinib in newly diagnosed patients, where patients were randomized to 80 milligrams a day versus nilotinib 300 a day. And the primary endpoint, this is a new endpoint that they're starting to use now, is TTDAA, which is the time to discontinuation for an adverse event. So again, they're really concentrating here on the adverse event range. And if you look at that, the probability of discontinuation of adverse event, this is nilotinib and asciminib. You can see that this was when the first reported at 4 years. This is now carried on longer. Again, about half as many different patients have to discontinue in the nilotinib versus the asciminib arm. Um, there's fewer patients with AEs that have to be discontinued, 7% versus 16% for nilotinib, and a 54% chance of AEs was maintained over the time from this time to this time. So I think most people now are thinking that this drug is going to be a little bit better tolerated and get the same efficacious bang as the second generation drugs. Um, this is looking at MMRs and DMRs, and it looks like, again, that early on, if you look at MMRs, MMR4, 4.5, very, very low around 12 weeks. Asciminib looks like it's a little bit more effective. At 24 weeks, it's starting to catch up, and a lot of it's starting to catch up. And at 48 weeks, if you look at these various levels of MMR, MMR 4.5 and 4, it's kind of caught up. So the efficacy, asciminib may be a little bit faster, but the second generation nilotinib seems to kind of catch up over time. So again, I think the way to look at this drug is it's essentially has the power of the second generation drugs with probably a better toxicity profile. Now, speaking of toxicity profiles, you've got to worry about these in their patients because, especially in the US and Europe, when they're diagnosed a little bit older than in India, Africa, etc., most of us, as we get older, start getting comorbidities. And so this is sort of in the European registry, the levels, the types of comorbidities that patients have, the percentages of them. And this is the percentage of people that have some comorbidities. I'm kind of shocked that any place in the world only has roughly half people without a comorbidity, not in my practice. Being C2 and beyond, you've got at least a quarter of patients who have something to worry about when you give them some of these drugs. And these are the type of toxicities that you all know about. Common toxicities with these drugs are the myelosuppressive effects, myalgias, and fatigue. But then all of these drugs have specific toxicities. I'm not going to go through these all, but you can, when you have someone who has a comorbidity or develops a side effect on these drugs, these have enough non-overlapping toxicities that you can usually come up with some secondary drug to give them to take care of them. This is patient-reported symptoms on people, and this is just so we have the baseline of imatinib. This is the people who have some symptoms after 5 years. Surprisingly, with not a lot of them have nausea, abdominal pain, headache, diarrhea with imatinib. But if you look in the severe category, fatigue, muscle cramps, musculoskeletal edema, these drugs, while they're well tolerated, especially if you're like myself, I do a fair amount of time doing bone marrow transplant, but they're still enough to really cause a adverse in the quality of life. So there's clearly a lot of patients room to improve on the baseline of imatinib as far as drugs that they can take and tolerate. Because in the end, if they don't, taking and tolerating drug affects not only just quality of life, but also the chance that people are going to keep taking their drug. And so you don't want to lose efficacy because people just can't tolerate the drug. So then you can ask, like, well, what things really got a patient walks in the door of CML? How do you pick a drug? And these are the sort of the type of things that I think kind of affect what you're thinking about. One is the aim of therapy for the patient preferences. So is it just survival or if it's TFR? If you're a guy my age, really maybe all you want to do is get a survival benefit, right? Because the chances are that something else besides the CML is going to kill me. And for that, imatinib is just fine. Or if you've got a patient who's kind of a cardiovascular cripple, imatinib will be just fine. If you got a younger person who want to get to TFR, then you should be thinking about second generation drugs. CML risk category, we'll talk about this a little bit more. Higher risk category has higher risk of getting into accelerated phase blast crisis, which is where you don't want to hit people. So these are patients who should put it from a second generation drug with more efficacy. Ease of administration, this really is only a major issue with nilotinib, which is a twice-a-day drug. Comorbidities, we talked about that. Possible drug interactions and cost, which depending on where you live in the world, can be a big thing. Um, Mostly in my neck of the woods, this is kind of how I rank them, one, two, and three. But these factors aren't necessarily of equal weight and change from patient to patient. So in some patients it could be cost the main thing, and some people it could be comorbidities. But in general, most patients, this is sort of how things are ranked for me. Um, we have different, all sorts of risk scores, um, and they all work. The so-called Hansford, the ELN guidelines, they all work to differentiate. And the reason they probably work is that in all of these scores, part of the things to calculate the clinical scores, age, white count, spleen size, and the like. And while, for instance, spleen size isn't a great measure of disease activity, it's a rough measure because at one point patients started off with a normal size spleen and now they have a large spleen. And how fast they get from normal to large may differ from patient to patient, but it does sometimes something that does track with the length of time that they've had be cerebral, which is what you're looking for, because the idea is that the more unexposed tyrosine kinase activity you have over time, the more chance you are of being put on the accelerated phase blast crisis progression cycle. There are all sorts of things you can plug in online to get scores. This is the ELTS score. And this is just looking at the European registries. If you look at ELTS, how often you see patients, and most of them are low risk, only about 15% high risk, but that varies again from country to country. And these do a kind of a rough job in scoring, the probability of overall survival by lowest to highest. And this just equates with how many of these people are going into blast crisis. Now, this is a paper we did a while ago looking at the biology of response in CML. And so this is Marin's paper looking at early molecular response at 3 months. The people who have a good response, that's their survival, versus a less than response, that's their survival. So for a pretty large gap here. This data was all before the age of second generation tyrosine kinases. So with second generation tyrosine kinases, these curves are a little bit closer. But the idea is early response probably matters. And this is a paper where we looked at kind of outliers of response. We looked at people who had uh, a good response by these criteria at 3 and 6 months, and a molecular response of MMR by 12 months. So really, really good responders versus patients who didn't do that well. And we looked over 10 years. And what the remarkable thing was, is if these patients are defined up here, and there's very little crossover. So this really just shows that the early responders, 6 months responders, let's say, um, they stay that way. And the ones who don't get there never cross over. So I thought this was sort of remarkable. And now the other thing that we won't talk about here, but if you look at responders and non-responders, they have a very, very different biology. In the responder groups, if you look at it by RNA-seq and look at gene pathways, of the 20 biological pathways that are different between these guys and these guys, they're all upregulation of immune regulatory genes, T cell regulatory genes, NK cells, and inflammatory responses. So this is all the deep responders here in the blue. The deep responders are all driven by immunological pathways. So again, early on, if you're in this group, you're really doing well. This group, you don't cross over. So there's then kind of some rules. We talked about the disease, the patient's disease, and disease factors can help maybe choice. to summarize it, the two second generation TKIs and asciminib get better molecular responses. And so if you want to get people in TFR, that's a good idea. They don't do superior overall survival in imatinib, and imatinib has the lowest likelihood of serious and irreversible toxicity. But there's a lot of bothersome low-grade toxicities. And this just kind of just shows how the ELN sees things, or the NCN, the USA guidelines will see things, where low risk calculations by Sokol, Hansford, etc. You get first generation or second generation, and these are all listed alphabetically, so it doesn't say that they're preferred imatinib. They just do things alphabetically in the NCN. But if you're intermediate or high risk, then you can really should be thinking about second generation or the allosteric asciminib. In a flow diagram, I love flow diagrams. Here's how you can imagine it. You got a 70-year older person, low life expectancy. Um, if if yes, that should be yes, huh? You get imatinib or maybe some reduced. But if you're younger, no comorbidities. If you have a high score, you get second generation. If you get a low score, you can say, well, do I want to get a DMR and get off therapy? If you do, second generation. If you really have no interest in getting DMR, then imatinib is fine as well. Another way to look at it for Jorge, just so you have different ways to think about this. Same idea, treatment goals. If it's just cost, you should take imatinib or some generic. If it's survival, you can take any of them. If it's TFR, you go for a second generation or asciminib. If it's tolerability, if you got atherosclerotic stuff, you go for asciminib. That didn't show up here, but asciminib or imatinib. And if it's any other toxicities, you just basically go by, what toxicities they have. And asciminib is probably going to be your most best tolerated drug. And we'll talk about in a while AXL1 mutations, and we don't know what to do about those. So obviously now I'm transitioning to resistance and relapse. And I'm going to transition to some coffee first. And we're remarkably on time. So there's all sorts of complicated plots about when you should consider changing therapy. And it was Einstein that said you shouldn't memorize anything you can look up. So the only thing you need to memorize is that you should think about changing if people aren't hitting their milestones. And there's two reasons that people can't hit their milestone, especially early ones, is that you have bad biology or bad adherence behavior. And that really is what complicates the early 3 and 6 months starting points, because many patients, at least I'm talking about, the European and North American experience, when they are diagnosed with CML, it's in a routine physical insurance stuff and the like. They have a high white count, and then you go investigate. They haven't been really sick with their disease. And so when you start them on tyrosine kinase, even though they're well tolerated, you make them sicker than they were when they started therapy. And so it often takes people a while to get used to that. And so there is some not taking their medicines or trying to change the schedule of the medicines and the like. So often the 3 month molecular point can be a little bit inaccurate because it really doesn't reflect people being on their drug all the time. Certainly, if you lock someone in the room or did like they did in the old TB days where they had to come into your clinic every day to get their TB medicines, if you watched them swallow their pill every day, and knew they were getting it, and at the 3 month mark they had a poor molecular response, then you should change their therapy without any doubt. But for most patients taking it at home, you really don't know that. So you really have to kind of take that first endpoint with a bit of a grain of salt. Unfortunately, resistance does occur in CML, probably somewhere between 10 and 20% of patients with chronic phase disease. So they either have intrinsic, which means they have some resistance from the get-go and have a poor response, or you have sort of clonal disease where you get rid of the clone that responds, and then after some period of time, a resistant clone emerges resistant to TKIs. And these are typically, we first centered on those mutations in the ATP domain that we talked about, the point mutations, and these are a bunch of them here. And we have ways where you can have, these are all contrived experiments using cell lines, but you can get an idea of like which drugs will probably work with which mutations. And so if you had a patient on imatinib that had a E255V mutation, you probably wouldn't want to treat them with nilotinib, but you probably would say, okay, maybe dasatinib was the best bet. So there's a bunch of different grids like this, and they work reasonably well. There are sometimes you'll find a person that shouldn't respond to dasatinib that does, or vice versa. But there's a pretty good guideline if they have a mutation about which ones to switch to next. But now that we started looking recently in the last couple of years, we're finding that for the usual candidates of myeloid malignancies, we see these more often than we thought in at diagnosis. And so probably about 20% of patients, you'll find some other mutation in a myeloid gene. And the most common one from anywhere from 10 to 20% is AXL1. But you see some lymphoid type genes like Icarus, which is kind of interesting. And you'll see these chip kind of genes, TET2, DMT3, and the like. But the main one that you find is the AXL1 mutation. Um, we have now, these mutations. This is kind of looking at a drug here and which mutations you shouldn't be treated with. Like so, nilotinib, if they've got a 253 mutations, don't use that. Um, Again, the only one that really works with the T315 mutation is asciminib and ponatinib. Um, One thing you have to remember when you get resistance is are you at a point when you first become resistant that you're starting to play whack-a-mole, which is you see in most of the other leukemias, right? Where when resistance occurs, it's actually multiple clones, and what you're doing for the rest of the time is getting rid of the sensitive clones and just allowing more room to grow and food to eat for the resistant clones. And so these are looking at patients who have relapsed on imatinib, and then you put them on a second generation drug and what to expect. One thing that's really interesting is that very high rates of discontinuation rate of the second generation drugs in these. And we don't know if that's if there's some unique selection factor in people who are in imatinib resistance that's causing tolerance issues. But you can see these are all really, really high discontinuation things. So that's one thing to worry about is when you have to switch drugs, are you going to be able to keep people on drug? And then you look at things like complete CCYR, it's not really great in follow-ups of 2 to 5 or so years. So only about half of people getting back to CCYR, which we know is a thing that we need to get to improve survival and decrease the progression to accelerated phase and blast crisis. And so remember, when people come visit, high rates of TKI discontinuation, low rates of CCYR, and so the issue is resistance forever, and don't forget about transplantation. So, in our institution, what we usually do if people are resistant to a TKI is we try to get them on another second generation TKI, and if that's great, fine. But we also start working up donors for transplantation because the thing you don't want to do is keep shuffling them through TKIs and then have them show up with accelerated phase or blast crisis, because then you've really lost your chance because overall survival for chronic phase patients with allogeneic transplants, 80 to 90%. Accelerated phase, it's half of that, and blast crisis, it's half of that. So you don't want patients to show up in your door with progressive phase disease because your chance of curing them is greatly reduced. So this is sort of a kind of a spectrum of mutations that you find with people at diagnosis. And this is from Sue Branford in the Adelaide group. And you see the AXL is the most of them. You get a scattering of other mutations. But the thing that's interesting is AXL mutations have to seem to affect response. So this is your MMR at 12-month rates, and this is with no mutations or other mutations. That's exactly what you find. But well less than that if you also have an AXL1 mutation. This is another example of this, looking at mutated AXL1 and failure-free survival. And no mutation, other mutations, and then the AXL1 mutation. Again, these are a diagnosis. And then the curious thing is that at diagnosis, if you have an AXL1 mutation, the risk of you going on to acquire a tyrosine kinase domain, it's about 20%. which is kind of wild when you think about it. So what is it about an AXL1 mutation that makes you go on to later get a resistant mutation? This is again from the Adelaide group showing MMR, failure-free survival, and mutation acquisition for those patients started on TKIs, second generation, versus asciminib. And the thing to underline here is that whereas asciminib, we've been seeing lots of good things about them, it doesn't eliminate the AXL1 effect. In fact, it's maybe worse. If you look at freedom survivor here, then this is the AXL here, and this is the AXL here. And this may just be because of small numbers, but you're clearly not making things right by using asciminib. And there's a very high risk of acquisition of secondary mutations. Now, again, this is a small study. We don't know if this is real or not, but it's clear, I think, that asciminib probably doesn't rescue you from the deleterious effects of an AXL1 mutation. This is work done in our lab. This is we have a large um, time that we spend in trying to deal with CML patients in low and middle income countries. These are mutation analysis we've done by dried blood spots from patients in the Max Foundation who have resistance. So these are patients not newly diagnosed. These are patients who at some point have declared a resistance. And one thing we find is that of these people, roughly about a third of patients have an ABL mutation. But if they have an ABL mutation, look at this. About half of them also have an AXL1 mutation. So again, a very, very high co-migration of ABL mutations with AXL1 mutations, which is kind of really remarkable. Now, we talked about if you have to use a second generation drug. Well, what happens if you blow by that? If you can't get someone to transplant, you have to give them a third line of therapy. And this is just looking at numbers of very small studies. But the probabilities of CCYR by what type of treatment you finally get. So if you get post-imatinib and dasatinib, if you get bosutinib, only about 20% of patients get a response. Dasatinib, 30%. Ponatinib, about 50%. And this is post-imatinib and nilotinib, where ponatinib again is the highest. So ponatinib clearly has a role in if you have to get to a third line agent versus these other second line agents. Asciminib, we don't have the data for them, but I suspect will be about the same. The other place I think that ponatinib has a real role is if you have resistance that has no ABL tyrosine kinase mutation. Because in that case, you can assume that the resistance isn't being driven by BCR-ABL itself, because presumably that's blocked if it doesn't have resistance. So it must be some other tyrosine kinase or some other molecular pathways. And of these drugs, ponatinib has the widest berth of inhibiting tyrosine kinases, so kind of all the off-target stuff. So it's the dirtiest tyrosine kinase. So in the situation where we have resistance that isn't driven by BCR-ABL, I think it makes a lot of sense to use as dirty a tyrosine kinase as possible to block as many alternative pathways as possible. Now, when we look at this kind of work, most of the mutation stuff that's being done, at least of the BCR-ABL tyrosine kinase domain, is by Sanger sequencing. And the issue there is that there's a limit of detection of about 10 to 20%. If it's less than that, you really can't pick up the mutation. Mass spec is better than that. No one does it. It's too hard to do. Next generation is the one that most people rely on now. But you have to remember that next generation sequencing it's more sensitive, but conventional next generation sequencing isn't that sensitive. And that's because as you build these libraries, there are for next generation sequencing, there's an error rate of roughly 1 in 1,000 minimum. So that kind of puts a threshold on how your low level of sensitivity, because you'll never be able to look at anything less than 1 in 1,000 by most types of next generation sequencing. Droplet digital PCR is a little bit more sensitive, but it actually takes a lot of work to set up the primers and get that reaction going. So next generation sequencing, what people are heading at. This is so greater than 10%. A few of these had high level